すいません、殴り書きで。
それぞれ出す。なんでやってますよ。
Okay, good afternoon, everyone from Kathmandu Model Hospital. I am Dr. Uday Koirala. So today we are going to start this rural healthcare session. So I'd like to welcome you all. Since COVID-19 is still going on, so this time also, this APAN meeting is going to be virtual, and we all are here to start the session. This time, actually, this topic of our rural healthcare session is what is the role of urban healthcare centers to the rural healthcare centers. So there can be different ideas, different modalities which can be used by these urban healthcare centers to the rural healthcare centers, and telemedicine may be one of that, one of the mode to be used. So first, I would like to start with the introduction. To start, Annabelle, can you please introduce yourself?
Thank you so much, Dr. Koirala. There we go. Good afternoon, everyone. My name is Annabelle Brinkerhoff, and I am a second-year medical student at the Penn State College of Medicine in Pennsylvania in the United States. I'll be talking a little bit about my experiences with telehealth in Nepal and the US, and I'm excited to hear from you all.
Thank you. So from IOM, can you please introduce? From Institute of Medicine, can you please introduce? Sushmita, are you there? Okay. Next from Temdek Komatsu, can you please introduce?
Hello, can you hear me? Good
Yes,
afternoon,
yes.
everybody. Good afternoon, everybody. I'm Komatsu from Telemedicine Development Center of Asia. I'm a secretary of APAN Medical Working Group. Thank you for joining today, and congratulations on Dr. Udaya for your sessions. Thank you.
Thank you. Thank you. Pawan sir from ICT 4D.
Good afternoon. My name is Pawan Sakya, and I'm from ICT 4D. It's a non-profit organization working in Nepal on digital health. I'm also the Vice President of Telemedicine Society of Nepal. Thank you, Dr. Uday. Thank you, APAN, for providing me this opportunity to be a participant. Thank you.
Thank you. Thank you, Pawan sir. Shunta. Shunta from Temdek, can you please introduce?
Hello. Hello, this is Shinta Toimatsu from Temdek, Japan. I'm the engineer to support Mr. Roger in this session. Thank you very much. I'm looking forward the successful session. Thank you very much.
Thank you, Shunta. Shonakshi.
Hi, my name is Sonakshi. I am a second-year medical student with Annabelle at the Penn State College of Medicine in the United States. I'll be talking a little bit about my experience with rural healthcare as a global health scholar and the role of traditional medicine with improving rural healthcare access in Nepal.
Thank you. Thank you so much. Nirajanji from NREN.
Hello everyone, I'm Nirajan Parajali. I am supporting technical part. Thank you.
Thank you. Shushmita from AMSA or IOM.
Hello, namaste everyone. I'm Susmita Khatiora from Maharajganj Medical Campus, IOM. I'm currently second year medical student and acting as a secretary of the newsletter of AMSA Nepal. Thank you.
Thank you. This IOM, it is also working because we couldn't hear anything from your Department of IT, IOM. Sushmita, is it working or?
Yes, sir, it is working.
Okay, thank you. Thank you. So do you have any other friends? You have to
Sir,
introduce.
we are six of here.
Okay.
I would like to introduce. Okay.
Your video is so can you?
Sure, we are arranging for it. I think it will take
Okay.
just a minute.
Okay. Premila, will you please introduce yourself? Yeah. Premila. So with this, I'd like to start our session. First presenter will be Annabelle Brinkerhoff. She is affiliated to Peninsula State College of Medicine. She is a second-year medical student. She has in Pennsylvania. She has a Bachelor of Science degree in biology from Lycoming College. Annabelle worked in cellular biology and neuroscience research during her 4 years in undergraduate and completed an independent research fellowship. So here we'll be hearing her presentation on the topic telehealth around the globe. Annabelle, please start your presentation.
Thank you so much for that introduction, Dr. Correal. Let me adjust my screen briefly. Good afternoon, everyone. I'm very excited to be with you all today and to bring the perspective on rural telemedicine that I've developed over this past summer spent in Nepal, as well as my time working in the healthcare system in the United States. I'd like to disclaim quickly that the opinions that I will present are my own and do not represent those of my academic institution, and all photographs shared are shared with permission or are from the public domain. To give a brief overview of the trajectory of my talk today, I'll begin by introducing my background in the Global Health Scholars Program that myself and Sonakshi are members of. I'll talk broadly about trends in global telemedicine, and then I'll speak more specifically about the US and Nepal. I'll do some critical analysis of what I saw in both countries, and I'll conclude with a future vision for telemedicine. I live in Pennsylvania and attend medical school here. Pennsylvania is a primarily rural state. As you can see in this bottom left diagram, everything in green represents a rural area and everything in yellow is an urban area. So 19% of the population of Pennsylvania live in a rural area. Penn State College of Medicine very much emphasizes students working with the surrounding communities, with the rural populations, and I've been fortunate to experience a lot of that within the years leading up to medical school, as well as my years in medical school thus far. Penn State also emphasizes students' ability to learn about diverse healthcare systems. That is, healthcare delivery modalities different than those we're traditionally accustomed to, and we see in the US, which is exemplified through the Global Health Scholars Program. Myself and Sonakshi are a part of this program, which runs longitudinally throughout all 4 years of our MD program. Students within this scholars program attend one of multiple sites around the world. There are 9 different sites, and Sonakshi and I were in Nepal. We spent about 4.5 weeks there this summer, and we will spend a bit longer there at the end of our 4th year. The goal of the scholars program is to bring a more diverse perspective on healthcare delivery and develop a longitudinal relationship with the host communities of your chosen country. So the summer of 2022, summer passed, we were in Nepal and really just had an incredible time, saw so much. We spent some time in the capital city of Kathmandu, and then went to Bharatpur, where we participated in clinical rotations at Chitwan Medical College Teaching Hospital. We also spent a week in Bardibas with 4th year medical students from Chitwan Medical College, and we were really immersed in the rural healthcare delivery. We visited multiple levels of care delivery in the Mahatari province there, and the photos on the top of the screen are those that I took while we were in these locations. So from left to right in ascending order of resource availability and of level of care provided, from an urban health post all the way on the left, which you can see is a much smaller facility, all the way to the right, which is a hospital, but still quite rural in its location. Overall, the global utilization of telemedicine has increased, which is fairly obvious for anyone working in healthcare or around at the moment. But as we can see on the right-hand side of my slide, the use of telemedicine in rural settings has increased at a much slower rate than it has in urban settings. Pardon me. And when we arrived in Nepal and started to learn more about the process of establishing telemedicine in rural areas, this discrepancy began to make a little bit more sense. So when we met with Dr. Koryala, who is present today, during our first week in Nepal, and we're very fortunate to sit down with him for some time and learn about the efforts he and his colleagues have made over the past 20 years on bringing telemedicine to Nepal. As the photo on the top right shows, there's some very inhospitable territory in the country, and establishing this infrastructure is a real feat of human will. So beginning in 2002, when the first long-range wireless link was established in a rural area, all the way up to present, where there are regular interprofessional collaboration sessions, continuing education, telehealth discussions, really dynamic flow of information. It is a very strong development of telemedicine in such a short period of time, and was really exciting to learn about. In working with and meeting people in Nepal, telemedicine seems to be very widely accepted and perceived positively. Patients seem to accept it. In addition, it's getting care to patients that may have previously not had access to quality care, if any care. But due to political instability, providers seem to be cautiously optimistic, keeping in mind the state of Nepal's health system, while also trying to deliver quality care to rural populations who need it most. Now, telemedicine in the United States is a very similar situation in a lot of ways, which surprised me when I visited Nepal, and it's really interesting. I think you'll see 14% of the United States population live in rural areas, which doesn't seem like a lot, but that represents 60 million people. So that's still a very large population. Telemedicine was used infrequently prior to the COVID-19 pandemic and seen as sort of a inferior alternative to in-person care. After the pandemic began, we were necessarily doing a lot of visits using telemedicine. And at present, telemedicine is widely trusted, accepted, and used for about 20% of the outpatient visits in the clinics I shadow in. Very similar attitudes in the US towards telemedicine as in Nepal. Patients are appreciative of convenience. They're beginning to accept it more. Although trust in telemedicine varies a bit, especially among the older population who is potentially less familiar with the technology. This is understandable. Providers also are appreciative of the ability to follow patients continuously, to reach rural patients. But of course, there's the struggle of potentially losing personal connections and the increased difficulty of clinical decision-making without an in-person interaction. Now, these shared challenges exist in the US and Nepal, but seem to be ubiquitous in most countries using telemedicine in healthcare. Of course, there are these geographical constraints where the terrain is incredibly difficult to navigate, where there isn't cell service, political instability, or lack of government funding, the actual lack of software and hardware physically. And then often overlooked is the human challenge to implementing telemedicine and doing so successfully. There's some aspect of patient resistance, of being fearful of this new technology. And additionally, there can be elements of physician fear or lack of confidence in providing clinical care using this modality. I'm now going to do a little bit of comparison between Nepal and the US, but before I do, I'd like to emphasize that I'm not qualified to rank anything, and I'm not attempting to rank anything. I'd like to illuminate the strengths of each system and kind of provide an opportunity for idea exchange. The most stark difference I saw in telemedicine between the two countries was the utilization by specialty. So the focus of telemedicine in Nepal, not exclusively, but a large focus is on procedural technique and on a more invasive scenario in which we're using telemedicine, where in the US, it's used for psychiatry, it's used for outpatient visits, it's more of an outpatient, less invasive use. And I think that there could be a really big potential for the US to increase its breadth of telemedicine utilization because it's being done so successfully and so frequently in Nepal. Additionally, the knowledge sharing networks are extremely robust in Nepal. These are photos shared from Dr. Koryala, as are several others in my presentation, but really exemplars of how many people participate in bringing knowledge around the country and really benefiting excellent patient care at the end of the day. This is more difficult in the US because of insurance protocols and of institutional licenses, and there's a lot of restrictions, but this is very inspiring and something I would love to see develop more in the US. Now, in the US, I've seen telemedicine used widely for continuity of care, for patients with chronic diseases or recovery from an acute procedure or surgery, especially rural patients, those who may not be able to return to the doctor's office for a follow-up visit. Were able to use telemedicine to meet them in a way that's convenient for them, but still medically sound, and keeping them within the system. When I was at Chitwan Medical College Teaching Hospital, I spent most of my clinical time working in obstetrics. And I realized that there were a very low number of patients coming in for postnatal care follow-ups, and was told that there's a pervasive superstition or belief that after a mother gives birth, they're not to leave their house for 10 days afterwards. Now, because there is a really high chance of complications in that 10-day postnatal period, this is concerning for mortality. So if there were to be utilization of telemedicine in this area, we'd still be honoring religious, philosophical, ideological beliefs while also delivering medical care. And finally, this is not telemedicine, but this is an example of rural healthcare that I'm excited to be a part of. My school is piloting a mobile clinic, which is a vehicle with 2 exam rooms functioning like a small clinic that we drive to the most rural parts of Pennsylvania, and provide completely free healthcare, basic healthcare, but free, and referral services if needed. But this has already been a massive asset, and I'm excited to see how this could expand in other countries to reach rural people. So in summary, telehealth has proven itself incredibly useful, and specifically to rural populations. Nepal is using telehealth successfully in multiple ways, as is the US in different ways. Both countries are improving patient outcomes really significantly. But by initiating this conversation and acknowledging some of the system level barriers that do remain, there are still some very concrete opportunities for idea exchange and technique enhancement that I am very excited to be a part of. Thank you so much for your attention. That is all. And specifically, thank you to Dr. Udaya Koryala for his instruction and collaboration, and to Sonakshi Sharma as well. Thank you.
Thank you. Thank you, Annabelle. It was really excellent presentation. So it was presented very differently and very much analytical. Okay, so there are many things to learn from this presentation, I think. And thank you very much. If there are any questions to Annabelle, please. So here are our guests from Sankara Netralaya. Dr. Sheila, are you there? Or can you please introduce yourself from Sankara Netralaya? Here is our chairman from Medical Working Group, Asia Pacific MS Network, Dr. Tomohiko Moriyama. Will you please introduce Dr. Moriyama?
Yes.
Yes, please.
Okay. Should I have some comment on that?
Will you introduce yourself and?
Oh, sorry for that. Hello, everyone. This is Dr. Tomohiko Moriyama, Director of TEPDEC and also the Chair of this Medical Working Group. Thank you for this wonderful topic, and I will enjoy the discussion as an attendee. Thank you.
Yeah, thank you, Moriyama. And here is Neeraj Acharya from NN. Will you please introduce?
Hi, Namaste. Good afternoon. I'm Neeraj Acharya, and I'm working here in Nepal Research Institute in the telemedicine activities here in Nepal. Thank you.
Thank you, Neeraj. Next,
Dr. Uday, I have a question to the first presenter.
yeah, of course. Yeah,
Can I? I was really surprised to know that the 90% of Pennsylvania people are living in a rural area. So I haven't been to the USA, unfortunately, but yeah, I'm surprised to know that. So my question is that the USA is the most developed countries in the world, Then so what is the similar part between USA and Nepal in terms of rural healthcare?
Thanks so much for your question. And I want to clarify briefly, 90% of the land in Pennsylvania is considered rural.
I'm sorry.
20%, I just wanted 20% of the population lives there. So 80% is concentrated in the urban areas, but still a large number. Similarities between the US and Nepal in terms of rural healthcare delivery, I was surprised at how similar the barriers to access are. Governmental resource allocation trends away from rural areas because there's less people per square mile. So I don't know how financially or otherwise they would rather push resources towards urban areas. But it seems that support from higher up is a difficulty in both countries, as well as physically implementing the technology, right? So in the US, a lack of cell service is pretty common. In Nepal, having cell towers put up is necessary. So very similar difficulties, which I think could be useful for some collaboration and work together towards common solutions. Did that answer your question?
Yeah, clear me. Thank you so much.
Thank you, Annabelle. And this question we'll be asking you again and again because we have to have more similarities, no? So our next presenter is Sonakshi Sharma. She's also from Pennsylvania State College of Medicine. She is a second-year medical student and a part of the Global Health Scholars Program at Pennsylvania State College of Medicine. She has a goal to develop sustainable global health initiatives as a future physician. So will you please start, Sonakshi?
Absolutely. Let me get situated. All right. Good afternoon, everyone. And thank you for that introduction. I'll be giving a short talk today about the role of telemedicine in rural healthcare access in Nepal from my perspective as a global health scholar. This is a brief overview of my presentation. I will be starting with an introduction to the Global Health Scholars Program, describe the global goals for rural healthcare, the background to rural healthcare in Nepal, our experience in Bardibas, an introduction to traditional medicine, and a proposal that we are conducting a study with, and my visions for the future. I have no conflicts of interest to disclose, and the views expressed in this presentation are solely my own. So before we begin, I'd like to explain a little bit about the Global Health Scholars Program, which is really just an innovative approach to allow students and faculty to participate in community medicine around the globe. We were able to, as Annabelle mentioned, take a month-long trip in various areas in Nepal and get an introduction not only to the community and the culture, but also to the healthcare system in Nepal. Before I talk about Nepal rural healthcare, I'd like to explain the global goals in this field. The World Health Organization identifies nearly half of the world's population as living in a rural or remote area. Over 80% of the world's extremely poor live in rural areas, and rural healthcare access for these reasons is imperative for achieving universal health coverage. It's also estimated that 2 billion people live in rural areas around the world and do not have adequate access to the essential health services that they need. This situation holds true in Nepal as well. Rural populations face healthcare accessibility issues related to physician shortage, geography, cultural factors, political instability, and gender. And despite rapid urbanization, as of 2015, 81% of people in Nepal continue to live in rural areas. The most recent Living Standards survey conducted by the Central Bureau of Statistics reported that 41% of households do not have access to a local health post or sub-health post, and that almost 80% do not have access to a public hospital within 30 minutes of their home. Now, many people living in rural areas rely almost exclusively on the services provided by local health facilities. And so when these essential services are not available locally, geography, distance, and costs become really prohibitive barriers. And this map here shows very well why that is. We can see that one of the few built up areas is Kathmandu Valley, which is the capital. And all around it, we see grasslands, forests, agricultural areas, and in the north, mountains. And so transportation access and geography are really quite prohibitive for many. And previous studies have shown that longer distances and travel times actually lead to poorer health outcomes. And this has been called the distance decay association. And this disproportionately impacts lower income countries like Nepal. There have been very few studies to actually assess the barriers and attitudes regarding rural healthcare in Nepal. One recent study by Ashworth and colleagues in 2019 assessed the factors and attitudes associated with healthcare accessibility in a rural area outside of Lumbini. And they reported longer times to access a hospital in rural areas than the national average. They also showed that those with a lower secondary education, lower socioeconomic status, had larger barriers, and they also showed a gender disparity in accessing healthcare. We found these factors to be true in our experience as well. As part of our exposure to community medicine, we were posted in Bardibas, which is a rural area of the Mahutari district. And here we got to see the various tiers of care, starting at the top with Bardibas Hospital. And the leftmost picture is a view from that hospital. And as you can see, it was really quite remote, all the way down the tiers from primary health centers, health posts, sub-health posts, and urban health centers. So in Bardibas Hospital, we saw that it was located in a very rural area. It was miles away from the main highway, and the road to get there was quite underdeveloped. And so this made it clear to us before we even arrived at the hospital that accessing care here would be difficult for patients without access to transportation. The hospital itself also was currently under construction and had few resources. They had a 4-bed ED and 2 physicians for all outpatient care needs of the hospital, which saw over 100 patients a day. So it was clear that these physicians were quite overworked and under-resourced in their practice. This held true down the tiers of care as well. It was clear at the urban health centers and the health posts that they were under-resourced. The urban health center saw over 10 patients a day in a very remote area and was staffed only by a single auxiliary nurse, along with the health post, which was also staffed by nurses. And these centers are really only able to provide very basic care, such as first aid and basic immunizations. So in speaking to patients, the factors that we've covered so far, like transportation access, physician shortage, education level, gender, geography, and socioeconomic status, were certainly present as barriers to accessing healthcare in rural regions. But there was something much greater also impacting healthcare access. And these factors were really just the tip of the iceberg, so to speak. The larger factor that we found was culture and cultural attitudes towards healthcare and ability and willingness to access government hospitals. Part of that culture was low trust and understanding in the healthcare system. And talking to patients, it became very clear to us that allopathic medicine was not at all the pervasive form of healthcare in Nepal. Instead, traditional forms of medicine were much more trusted and readily accessible to Nepalis, especially those in rural areas. And we found that about 2/3 of the population actually relies very heavily on traditional medicine to meet their primary healthcare needs. Traditional medicine is made available via various forms of delivery, such as tribal lore, herbal remedy at home, even faith healing. But the medical systems that we'll be touching on today were really prevalent, are Ayurveda and the Amchi systems. One very compelling statistic to demonstrate just how prevalent traditional medicine is in Nepal, we saw that it's estimated that while there's one physician for every 20,000 people, there's more than one healer for every 100 people. A study in 6 rural villages in the Gorkha district actually showed that there are 455 traditional practitioners with no government health facilities within a 30-mile radius. And so ethnographic evidence really continues to suggest a culture that is heavily dependent on village healers and using locally sourced medicinal plants. In speaking with patients, they described to us that traditional medicine is considered safer. It's seen to have fewer side effects, better patient tolerance, significantly less expense, and greater access and cultural acceptance due to its long history of use. So what exactly does traditional medicine entail? So first, Ayurveda is by definition the science of life. It dates back to around 5000 BC and is one of the oldest healthcare systems in the world. It conceptualizes disease as surrounding 3 humors, which are wind, gall, and mucus, and a disturbance in this equilibrium is thought to be the cause of disease. Tibetan medicine focuses on the mind, body, spirit, and physical world connection, and largely uses lifestyle modifications and dietary changes in order to modify disease course. And this is mostly prevalent in the mountainous regions of Nepal. So what is the role of these systems in improving rural healthcare access? In remote areas of Nepal, traditional practitioners can be trained to provide medical care through the existing health network, and they can improve acceptance of immunization, modern healthcare practices, and more. This has been done on small scales in the past. We've seen that traditional healers can be trained to identify and refer patients with eye problems. Healers have been trained to identify and diagnose epilepsy and encourage patients to seek care. And way back in 1978, it was declared at Alma Ata that the mobilization of traditional medical systems would be crucial to make health for all a reality, not just in Nepal, but around the globe. And this is largely because healers are familiar with the social and cultural backdrop of the society that they practice in. They're accessible, they are respected, and they are very experienced. The big barrier to utilizing this asset is that many modern medical practitioners view the increasing use of traditional medicines as a failure of allopathic medicine. And to quote a physician we encountered in Nepal, traditional medicine is full of spiritual and magical practices, whereas modern medicine is seen as being based on logic and verifiable by experiments. And so these two forms of healthcare are seen as opposites, and any meaningful collaboration is excluded as a result. So it's clear that traditional healers are a potential asset that can improve rural healthcare access and have been largely ignored by allopathic physicians and by public health initiatives. Closer collaboration between allopathic and traditional forms of medical practice can be of benefit to all concerned. And it is in this vein that we are conducting a study to compare outcomes using Ayurvedic, Tibetan, and allopathic medical approaches. Our project aims to identify and quantify potential differences in outcomes among patients with type 2 diabetes treated with each of these avenues of care. And our goal with this is really to establish the legitimacy of Tibetan and Ayurvedic medical approaches in treating disease to hopefully encourage collaboration between allopathic and traditional forms of medicine. We will be measuring outcomes at 6 months following initiation of treatment and utilizing various patient-reported parameters to measure success of various approaches. Our future hopes for these projects is really to encourage collaboration between healthcare professionals practicing allopathic medicine and traditional medicine, and using this to not only better understand the landscape of rural healthcare in Nepal, but to improve access to healthcare as well, using an existing infrastructure. Thank you, and I welcome any questions.
Thank you, Sonakshi. It was really very excellent presentation, and things can be looked as you have looked. So it was really different, and we are really excited to be your friend. And Dr. Sanjay also had said that he will be attending. Do you have any message from him?
I don't think so. It's actually 4 a.m. here, so he might just be asleep.
And you both look so fresh. That is almost in the early morning, yeah. So, but you both look fresh. So, is there any question to Sonakshi?
Can I have some question?
Yes.
This
please.
is Dr. Mariam from Japan. It's really interesting, and that's a very exciting presentation. Thank you for nice presentation. I just wondered one question. You will check the hemoglobin A1C level to find out the efficacy of traditional medication. As you know, then some of the Chinese herb is quite effective for some diseases, such as ulcerative colitis or something like that. So that I think that there should be some possibility of the medical efficacy in these medication, even in the traditional medicine. I don't think it's magic, just magic. But I suppose that some people say that to change their lifestyle, once they change the feeding behavior, the hemoglobin A1C level will be changed. So it is sometimes very difficult to evaluate the efficacy of the traditional medicine when they change their daily behavior. So is there any the measures against this kind of biases to your study?
Right. So thank you for your question. To clarify, the part of my presentation where I referred to traditional medicine as having magical and spiritual connections, that was more public perception of these practices, not necessarily the reality of these practices. As we saw when we were able to visit, they are quite advanced and quite established in their methods of care. In order to kind of control for the factors that you mentioned, which are the dietary modifications and lifestyle changes that are quite emphasized in Ayurveda and in Tibetan medicine. This first study, which is really a pilot, will not really be accounting for those because, as we've said, there's a great deal of variability in how different practitioners of Ayurvedic medicine will choose to treat diabetes. The same is true for the AMG system as well. And so this first study is really a global approach to care. So we are not identifying a specific treatment within each of these branches, but rather comparing a holistic approach of Western medicine compared to Ayurvedic and Tibetan medicine. And following this study, based on our results, we will be conducting more stringent trials. And that's really kind of the next step. This is our first kind of platform to build off of. I hope that answered your question.
Okay, thank you. Very challenging.
Yes, yes, thank you. But I think this, because they have talked about this study, and Nepal may be your best place to study these type of research, because we have Indian medicines, Chinese medicines, Tibetan medicines, so many traditional medicines as well. So, and I really like the topic, and let's see how much we can do. So next presenter is Dennis Batangan. But because of his busy schedule and an emergency meeting with the government, he couldn't attend, but he has sent us the recorded presentation. He is a faculty and research scientist at the Antonio de Manila University. And his research associated in Institute of Philippine Culture, School of Social Science. So we'll be presenting his recorded this presentation.
Good day to everyone. This is Dr. Dennis B. Batangan from the Philippines, and would like to thank the organizers of the Rural Healthcare session of APAN for the invitation to present in this particular session. So my presentation is entitled Unpacking Health Information System Issues in Citywide Health Systems, a preliminary analysis of 3 Philippine cities. The objectives of my presentation are as follows. Number 1 is to provide an overview of the universal healthcare implementation in the Philippines. Number 2 is to discuss implications of further local autonomy to health information systems also in the Philippines, and to present updates on local health information exchange models in 3 Philippine cities. These 3 Philippine cities are the cities of Pasig or Pasig City in Luzon, as you can see on the map, the city of Iloilo or Iloilo City in the Visayas, and Cagayan de Oro City in Mindanao. As you know, the Philippines is an archipelago of more than 7,000 islands and more than 100 million population. And I'm just focusing my presentation on these 3 cities from the geographical areas or Luzon, Visayas, and Mindanao. The Universal Healthcare Law was passed in the Philippines in 2019, and this diagram shows the goal of universal healthcare, which is that every Filipino has access to quality, affordable health services when and where they need them, without ever failing into financial hardship when these services are availed of. And I would like to highlight in this diagram or in this slide the role of e-health in the implementation of universal healthcare as a health system approach. And it is actually located as part of the governance mechanism or reforms in the implementation of the universal healthcare in the Philippines. A very significant shift with the implementation of universal healthcare in the Philippines is actually the further autonomy given to provinces and cities, such that there is now more impetus for local health systems development through what we call the citywide health systems and the province-wide health systems. I wouldn't go into the details of how these province-wide and citywide health systems operate, but I'd like to highlight here that in this particular reform initiative, the administrative control of the central government to the Department of Health becomes less. And you'll see here dotted lines coming from the central government as it interacts with the provinces and cities in the Philippines, indicating more local autonomy or further local autonomy to local government units in the Philippines. As far as the local health system maturity levels are concerned, or how this particular universal healthcare implementation should proceed, there are 5 key result areas for integration characteristics for universal healthcare. One is the strategic and investment planning. Second is human resource for health management and development. Third, which will be the focus of my presentation, is information management systems. Fourth will be epidemiology and surveillance systems. And fifth is referral system. For the information management system, there are key results areas that looks into validated electronic medical record system that links the members of the PCPN is the primary care provider network to secondary and tertiary care providers within the province-wide and citywide health system. Again, highlighting here the focus of the integration of the province and citywide health systems. As far as the health information system is concerned, we are moving also, because of the further autonomy of local health system, for further local health system development from national health information exchanges to local health information exchanges. What you see here on the left is actually a diagram of the national or the Philippine Health Information Exchange, for which now we are evolving or developing more and more of local health information exchanges, which are situated or located at the corresponding cities, citywide health systems or province-wide health systems. I'll show you more detail on this in the other slides of this presentation. I'd like to also highlight that as these health information exchanges are evolving, these are also influenced or affected by other related issuances. For example, in the Philippines, we have the Philippine ID system, the Data Privacy Act, the COVID-19 related issuances, and then, of course, the issuances mainly coming on universal healthcare coming from our Ministry of Health and our health insurance agency. Moving forward, in terms of how it is now being customized or operationalized in one city, this is Cagayan de Oro City, which is in northern Mindanao. I'd like to show you the local health information exchange open architecture design, for Cagayan de Oro City. What you see here is actually the installation of the smarter and integrated local information system interoperable layer, which you see in the middle. This is a project that I collaborate with the Department of Science and Technology and of course the local government unit of Cagayan de Oro. Essentially, the open architecture, open LH architecture requires that there should be authoritative registries. You see here on the left, that means the patient registry, health facility registry, and the health worker registry. Those authoritative registries become now the main or common reference of the participating institutions or facilities so that they can generate reports internally within the local government unit and to the national government agencies requiring specific reports. This is still a work in progress that is currently happening at the city of Cagayan de Oro in northern Mindanao in the Philippines. Moving on to the two other cities, which is Pasig City and Iloilo City, of which I am also fortunate to have the opportunity to collaborate with, we actually had a different approach. The approach that we are doing here is actually more programmatic. We started with the non-communicable diseases and then developing a multi-program mapping tool. What you see here on the left actually is the dashboard of that particular local mapping tool for NCD, and of course the maps, wherein the health centers are located. This is now happening as well, in two cities in the Philippines, which is in Pasig City in the Luzon group of islands, which is in Metro Manila, and in Iloilo City, which is in Western Visayas, in the Visayas island groups. These are the features, of that NCD local mapping tool. It has a dashboard, which I showed you earlier, which shows key statistics and visualizations of graphs and charts for NCD data, and also the maps, for the facilities. It also has a patient registry, which lists the patients in the database, including facility visits and treatment or management records. And there is also a filtering mechanism to be able to generate the reports or the data aggregates that you need. And of course, the reports, which is made compliant or consistent with the reporting requirements of the Ministry of Health or the Department of Health. We also installed or developed a data duplication and quality check module to be able to improve the quality of data for the system. An additional feature actually is a profiling list, for COVID-19 vaccination and other health services prioritization, which I would like to inform the group has evolved into a frontier technology project called Etsynovus, with the British Embassy in Manila. I hope we'll be able to have the opportunity to report on this project in the subsequent APAN conferences. What is evolving in the two cities of Pasig City in Luzon Island Group and Iloilo City in the Visayas Island Group is a similar local health information exchange model, wherein the NCD reporting system or MUPLOM is actually now being integrated into a bigger citywide health information system through an interoperable mechanism. Similarly, it has to be anchored on authoritative registries, meaning the patient registry, health facility registry, and the health worker registry should be authoritative and should now be and will now be the basis for the NCD reporting as well as the other health information system requirements for the city. In the case of Pasig City, we are actually working with a private provider for the city that is actually implementing the citywide health information system for Pasig City. And for Iloilo City, we will actually, or we hope to be working with another health information system mainly provided by the national government. So in essence, what's happening now in these three cities that I have shared with you is that in these three cities, in Pasig City and Iloilo City and Cagayan de Oro City, there are variations in terms of their implementation of their health information system models to comply with the citywide health system requirements of universal health care in the Philippines. So thank you very much for listening, and congratulations to the Asia Pacific Advanced Network Conference. And thank you again for inviting me and for this opportunity to share our experience from the Philippines.
Thank you, Dr. Dennis. So he actually has done so many research on this health information system, and he's a really good resource person for all of us to learn about this health information system. He has done many work in rural healthcare, especially in networking and this sharing the information as well. Our next presenter is Susmita Khatiwada. She is also another wonderful medical student. She is third year medical student at Maharajganj Medical Campus, Institute of Medicine. And she is currently acting as chapter representative of Asian Medical Students Association, AMSA, International e-newsletter from chapter Nepal for the tenure 2021-22. She also worked as secretary of e-newsletter for AMSA Nepal. And when I heard about this AMSA, I wanted to connect this AMSA with this Asia Pacific Advanced Network as well, because they are the future of APAN, I think. So it's really good to be part in this session. Sushmita, will you please first introduce your friends and then start your presentation?
Yes, sir. Thank you, sir, for this opportunity. Before starting with my presentation, I would like my friend to introduce themselves. So, guys, please proceed.
Hello, everyone. My name is Samir Serai. I am currently the second year medical student from Institute of Medicine. Currently, I am the secretary of academics for AMSA Nepal. Thank you.
Hello everyone, I'm Sanjay Sapota, medical student from Maharajganj Medical Campus and member of AMSA Nepal. Thank you.
Good afternoon, everyone. My name is Vikas and I'm a second year medical student from Maharajganj Medical Campus, currently working as the secretary of research from AMSA Nepal.
Thank you, guys. Now I'll be presenting on AMSA Nepal and its activities. Sir, may I start? Is my slide visible?
Yes, please continue.
Okay. Asian Medical Student Association Nepal is non-profit, non-political umbrella organization of medical students, which
Can you make it a full screen?
And please click enable editing.
Okay.
There, enable editing. Yeah. Yes.
Now it is visible, sir.
No, you have to share it again. When?
Yes. Is it visible now, sir?
Yeah, it's visible. No, okay, yeah.
Okay, I'll continue presentation. As I said, Asian Medical Student Association Nepal is non-profit, non-political umbrella organization of medical students of Nepal, which work under as a local chapter of AMSA International. So it is a representative organization of medical students which focus more on acquiring or providing knowledge through workshop, training, and applying that knowledge in action to provide community service to the people. So saying all this, AMSA work on three principal pillars of knowledge, which I already said that it focuses on medical and scientific knowledge, acquiring or providing medical and scientific knowledge and applying that into action, providing community service. And in doing all that, we come to interact with medical students within Nepal and in Asia Pacific. So it increases the bond and strength of the bond between medical students from different parts of the country. So actually it increases or strengthens our friendship. So every activity is conducted by AMSA Nepal falls under different subsidiaries. And that subsidiaries are subsidiary of academics, subsidiary of Asian Medical Student Exchange Program, e-newsletter, Journal of AMSA, membership, Global Health, and Alumni Club. In my subsequent slide, I'll be focusing more on the activities of different subsidiaries. Okay. Subsidiary of academics. Like subsidiary of academics focuses more on the knowledge pillar of AMSA, and in focusing that, it conducts webinar, training, and career talk program which focuses on what is the life beyond med school. And we have treasure hunt program that is conducted in IOM. Now we have another Journal of Medical Student, Journal of AMSA in Research, which encourages all form of scientific writing, research article, case report. And not only that, it also provides training to undergraduate students like us who are more interested in the field of research. Global health. We actually don't call it global health at Nepal. We call it public health mainly. And it focuses on providing awareness, and it also conducts like a health camp in different remote areas of Nepal, so that people who don't have access to the quality health service can get health facility for 1 day or 2 days according to the time frame of providing health facility through health camp. And in this health camp, we provide free medicine, free checkup, and we do that in collaboration with different organizations too. Here are footage of some health camp we have previously conducted. Now we have another is exchange program. In exchange program, there is a exchange of medical students between two countries. Like country means here chapter country, and one country act as a host country, and another country send delegates. And host country need to make all arrangement for delegates in their country. And during this exchange program, we focus more on academic part. What is the difference in the study or medical like a curriculum of different country, like host country, and that is from where the delegates come. And it also focuses on providing community service. During exchange program, we need to conduct like a community service, or like we can go visit orphanage, or we can conduct health camp, or what type of program is accessible at that period, we can conduct that. So it in and another at the same time, it increases or it strengthens the mutual relationship between medical students of two countries. And this year, we were able to conduct 2 virtual exchange program as COVID hit was there. So we conducted one exchange program with Malaysia, where we have 15 delegates from each country. And next we have conducted exchange program with Philippines, where there were 13 delegates from each country. And this all exchange program provide us better platform to learn about each other culture, or what we say that academics, and we provide social service with that exchange within that exchange program too. So here are some footage. Now we have mental health program. As I already said, this program fall under the subsidiary of academics, and the theme for this program previously done was diverse approach to mental health, and this focuses like mental health cannot be acquired in a single way or from single means. It needs a diverse approach. So within considering that, we conducted a program, mental health program in Asutapovan, where medical students were given session on yoga, meditation, and how to involve ourselves more and more so that we can acquire sound mental health. Now, inter-college tricep futsal tournament. It is more like a entertainment program which give a break to medical students from their day-to-day routine, that is day-to-day study, and a type of refreshment too. Now, Another is National e-Newsletter Contributors Meeting. This is also an annual program conducted by AMSA Nepal. In this, the contributors of AMSA International, the Aspire, are called, and we have like a third session. And for this year, we have a theme conducted program with the theme telemedicine in Nepal, where our respected sir, Dr. Uday Koirala was also there, and our Dr. Asim Bhattarai was also there. And both of them give us a good idea and quick review on status, approach, and delivery of health facility through telemedicine in Nepal, and we were enlightened for that. Other activities of AMSA are East Asian Medical Student Conference and blood donation program, art competition on different occasions, awareness program. Here are some footage of East Asian Medical Student Conference 2018, which was conducted in Nepal. During this program, there was participation from different Asian country, and they interact, they did conference, and they visited different places and learn about each other culture, each other like study pattern and everything. And we are glad to announce that EMSC 2023 is back to Nepal, or is coming back to Nepal. Now we have Autism Awareness Program. This program was conducted for community service under exchange program of Nepal with Malaysia. So in this program, we conducted a workshop in collaboration with Autism Nepal Care Society. And the theme for this year was feel the autism, feel the difference. That is how autistic children or autistic people are different from what we call normal people. They are also normal in some way, but difference is that they cannot perceive things like us, like they cannot get things like us in easy way. That was the main focus of the program. So, and we are very glad that AMSA Nepal got Best Chapter Award in 2019. And we have also visited orphanage, which was also conducted under community service program with exchange with Malaysia, Philippines. And the theme of this orphanage visit was oral and hand hygiene. And that this program focuses on how we can get sound oral and hygiene, and there was a demonstration, and here we have given toothpaste, brush, hand sanitizer, and everything that can be helpful in getting sound oral and hand hygiene. Okay, now we have program on World Environment Day. It was conducted I think some year back, and the theme of this program was a multi-sectoral approach to air pollution. You can see the footage here. And this is an art competition which was also conducted along with that World Environment Day. And look at that, this art, how it represents the condition of today's world, the level of pollution in today's world, and what is the situation. This art represents everything, I feel like. Okay, now National e-Newsletter National e-Newsletter. We have National e-Newsletter, the Trailblazer, which will be published very soon. And the theme for this Trailblazer 1 is LGBTQIA+ status in Nepal and beyond, which focuses how is the condition of LGBTQIA in Nepal, and what is the inclusivity of LGBTQIA in medical curriculum. So, saying all this, I'd like to summarize that AMSA Nepal has been conducting different program and different scope, diverse program are conducted by AMSA Nepal previously. And at the same time conducting all this program, it also focuses on providing health service to the people and making medical student like us socially responsible, that we feel that we need to feel what is going inside or going on in our society and how we can provide better health facility to people. Saying all this, I also strongly believe that we will conduct more and more program in collaboration with different organizations, and I think we can focus more on telemedicine too, because we are recently linked with Asia Pacific Advanced Network also, which and you are doing great in telemedicine sector. Thank you, sir, and thank you, everyone.
Thank you, Susmita. It was really a nice presentation, and it's amazing that you are doing so much of work. And I really wanted to introduce this group with APAN Medical Working Group. Our chairman, Dr. Moriyama, is also here, chairman of Medical Working Group. So I see it as a young APAN Medical Working Group, this AMSA, Asian Medical Students Association. So Dr. Moriyama, how do you like the presentation?
Right? Yeah, it's really interesting trial, and also it's an amazing. These are conducted by the medical students, right? And actually, in our countries, some of the medical students are aware of the medical disparity in the world and hope to visit and have some activities on developed countries, but not so interested in the world situation. And I was also, unfortunately. But anyway, it's really important to overcome the healthcare crisis and also overcome the medical disparities. So and from the viewpoint of telemedicine, we have been keen on to reduce medical disparities through the doctor's education, but also would like to work with another group from the different viewpoints. So we are more than happy to support the activities, and also if there is some opportunities, then we would like to collaborate with you guys. Thank you so much.
Yes, thank you. Thank you. Is there any question or comment to Susmita?
Oh, thank you very much. Yeah, it was quite wonderful session, and I also enjoy that. Thank you very much.
Thank you. Thank you. So here, Dr. Rajkumar Dangal is also present. Will you please introduce Dr. Rajkumar?
Namaskar, everybody. Namaskar. I'm working here in Dhaka. I'm Dr. Rajkumar Dangal, MDGP. And nice to be with you here. I was a bit late.
Thank you. Thank you, Dr. Rajkumar. He is now in Dolha doing a beautiful job, especially to the rural people. So this time our topic was urban health centers participation in rural healthcare development. Our Pawan Sakeshar, he is in ICT 4D, and he is also doing, actually connecting us with the rural part of Nepal. He has recently completed the ongoing Everest project. He is connecting Everest base camp with other cities. So Pawan sir, will you please say some remarks on this urban health centers participation in rural healthcare development?
Thank you. Thank you, Dr. Uday Koirala. And thank you everybody for joining me. Basically, I would like to summarize my experience in terms of providing digital health services in the rural context. Okay. With apology, I would like to switch off my video because of the internet problem. May I, sir?
Yeah, okay, sir. Yeah.
Okay. I would like to buy a few words from the previous speaker, like as Dennis said, interoperability, and as Annabelle said, expanding scope, and as Sonakshi said, traditional medicine. Okay, so these are the very key words that we've been hearing since we talk about the rural health. Okay, and since we are talking about linking the rural health with the central health or the urban health, so I would like to highlight and even try to brainstorm some of the points that we have come across as our experience. Number one is we always ask ourselves that, are we digitizing the health services so that unreachable communities in the rural area are reachable by doctors or paramedics over the means of ICT 4D? That has been our key component and key question when we design, when we deliver our project. And secondly, we also think of, so what are the basic things that we require to provide digital health services in terms of connecting the rural areas from the urban areas. Okay, so when we think of digital health, we think of digitization of the health services. Okay? And I think that's the key factor here when we think of digital health. When I see digitization of medical services, I think of for example, I always take example of stethoscope. Okay, so far the doctors in the rural area, they have been using the analog stethoscope, whereas the digital stethoscope, which can record the voice, the murmurs of the heartbeat, or they can record the wave file into the computer, which can be saved by the doctors in the urban area. So I'm talking about such kind of devices in terms of digitizing the health services. Okay. So how effectively can we use that? So that has been, that can be one of the brainstorming sessions for all of us in this forum. And secondly, when we think of digitization of services, we think of data. So how effectively can we store and forward data, or how we can store the data through health camps, through the information system, or even through the digital system that are available in the market. Okay. Because these data are very important in terms of analysis, in terms of further studies when we think of the health services in the rural area. Because in our experience, I mean, most of the people we live in urban area, we have easy access to doctors. Okay, and we can communicate very easily and thoroughly. Whereas people in the people in the rural areas, they have difficulty in communication. They have difficulty in accessibility. And I believe such kind of data is very vital in terms of analysis, for the treatment or for the research. And thirdly, so this has been a very key brainstorming part at our end, like how do we standardize these digital health platforms that are being developed, that are being established, that are being operated by different hospitals. Okay, I think it's high time we should be thinking of the standard platform, so to be used in community-based hospitals across the country, or even across the through NREN or through TEMDEC, through Telemedicine Society of Nepal. Okay, so these are the points that I would like to say and discuss in days to come. Thank you, Dr. Uday Koirala.
Yeah, thank you. Thank you, Pawan sir. So we have two medical students here. So they will introduce, please.
Namaste. My name is Dr. Kapil Devi Adam. I am medical intern.
Namaste, I'm Suman Kumar. I'm doing clinical rotations in Kathmandu Medical Hospital.
Thank you. Thank you. And now, now it's time to say goodbye. So we'll start from Amsa, Nepal. Will you please say some words to say goodbye? Sushmita? You are muted. Please unmute your mic.
Yes, sir.
Yes. So say a few words for the closing. Yeah.
Okay. It was a great opportunity, and I'd like to first of all thank all this team, Asia Pacific Advanced Network team, because we think that we are doing a lot, but when I joined this program, I feel like there are more things to explore, more things to conquer, and more things to more services we can provide to the community. And I learned more about telemedicine that in our contributors meeting, I also learned from you and our Dr. Asim sir. But here I can, the knowledge I get become elaborate, like elaborate form of knowledge, and there was a comparative how the in developed country also there is a disparity in the health facility, like the developing country like us, and I got to learn more. And here my friends are also so glad that they are here, and we got to participate in this program. This is like a type of what we call it, like fortune. I don't want to say, but it is a very great opportunity for us. And I would like to continue with more meeting of Asia Pacific Advanced Network. And we would like to connect these two organizations so that we can work together in days to come. Thank you, sir.
Thank you. Thank you. Annabelle, if you're still awake.
Yes, I am. I am so grateful to have had the opportunity to present with everyone here today and to hear your ideas. I am so excited about all of the information that I learned today and hearing everyone's attitudes towards global collaboration, especially on telehealth and rural telehealth. It's just very inspiring, and I'm excited to see the direction we go from here. So wonderful to meet you all, and thank you so much for listening.
Thank you. Thank you, Annabelle. Komatsu.
Yes, Dr. Udaya. Thank you very much for having your session this time as well. So actually, this time, unfortunately, this time as well, we have to do online meeting, virtual meeting. But next time, APAN55 will be hosted by a Nepal team here, and they're planning to do hybrid meeting. So it means we will be having opportunity to visit there to have on-site meeting as well. So I'm really looking forward to meeting you face to face next time. So it could be the first time to meet you, Dr. Udaya, face to face, right? Since we've been working 2 years ago. Anyway, so thank you very much, and congratulations the successful of your session. Thank you.
Thank you. Thank you. Yes, we would like to invite you all in the APAN55 in March 13th to 17th. And there will be Asia and Telemedicine Symposium in 17th and 18th of March. And you all are invited, and we hope that meeting will be in physical. So we'll be meeting in Kathmandu. Next, Neeraj Acharya.
Yes, it's quite exciting after a long time. It's a nice presentation. Cases are relating to Nepal as well. So thank you. So
thank you. Nirajan.
Thank you very much for a very nice, fruitful program. We are very warm welcome to invite you for next APAN55 in Kathmandu. Thank you. Thank you.
Pawan sir from ICT4D.
I just want to say thank you, sir. Thank you, everyone.
Thank you. Is there anyone from Sankara? Sankara Netralaya? Shunta?
Thank you very much. Yes, next time in Kathmandu. I'm looking forward. Thank you.
Thank you. Thank you. Dr. Moriyama?
Yes, Dr. Dea, thank you for a nice, nice meeting as well. And also, I really appreciate all the speakers, and especially for the medical students, because I was really impressed. You are very motivated and also very good to focus on the rural healthcare. As one of the teacher in Kyushu University Hospital, I'd like to encourage our medical student. Thank you.
Thank you. Thank you very much. So with that, now we have come to the end. But for all these connections, network, we have very important person here, Mr. Rosen. Rosen Sai, he's our engineer here, and he has made all this possible. So, Rosen, will you please say a few words?
Thank you, everyone, for your support. So, see you next meeting. Thank you. Thank you, Sundar.
Okay. See you all. Thank you. Thank you all for making this.
Okay, bye-bye.
Okay.
Bye.
Thank you. Bye-bye.
Thank you so much. See you again.